بسم الله الرحمن الرحيم. السلام عليكم. كل عام وأنتم بخير. I'm going to present novel insights about ST elevation myocardial infarction. Since the 2017 ESC guidelines of STEMI, many new topics have been addressed and others have been readdressed again. And we are going to tackle 5 main subjects in our presentation. First, the vascular access, what's new about it, the complete versus culprit-only revascularization, if there are any stent preferences regarding the stent design in STEMI patients, what are the novel concepts regarding antiplatelet strategies, and the uprising concept of anti-inflammatory treatment in STEMI patients. Starting with the vascular access, among the various trials that have compared radial versus femoral access in acute coronary syndrome in general and in STEMI particularly, Matrix trial comes as the largest. It compared the radial versus femoral approach among patients with acute coronary syndrome. It showed that there was no significant difference regarding the main primary outcome, which was a composite of death, MI, or stroke, according to the pre-specified alpha or cutoff p-value of 0.025. However, the radial access had a benefit in terms of reduction in net adverse clinical events, mainly guided by the reduction in major bleeding. Lately, in a safety and efficacy randomized trial that is specially dedicated to STEMI patients, the Safari STEMI trial have been released. This trial compared the radial versus femoral approaches among patients undergoing primary PCI for STEMI. It showed that the 30-day mortality was not significantly different between both arms, and also bleeding, whether TIMI bleeding, major or minor, or BARC classification of bleeding, or the need of blood transfusion was not significantly different also between both groups. So with this conflicting data, the cumulative evidence from randomized trials is important. Lately, a meta-analysis of 16 randomized trials showed that still the radial approach had benefit in terms of all-cause mortality, major bleeding, as well as vascular access complications. Now moving to the next subject, which is the complete versus culprit-only revascularization. Well, after the 4 major trials that have been previously published and upon which the latest ESC guidelines have upgraded the level of recommendation for complete revascularization, came the complete trial, which is the largest trial to tackle this issue of complete revascularization versus culprit-only revascularization. This trial showed for the 2 co-primary endpoints. The first was cardiovascular death or new myocardial infarction, and the second was both of cardiovascular death, new MI, added to them ischemia-driven revascularization. It showed that complete revascularization was consistently better compared to culprit-only revascularization. Regarding the timing of staging, in a sub-analysis from the complete trial that approaches this subject, which is the proper timing for staging of non-culprit lesion PCI. In this sub-study, patients were stratified according to the intended timing of non-culprit lesion PCI, where patients, some of them underwent the non-culprit lesion PCI in the index hospitalization, and others underwent the PCI in a scheduled appointment after discharge. And for the first co-primary outcome of cardiovascular death or new myocardial infarction, the benefit of complete revascularization over culprit-only PCI was consistent whether the procedure was done in the index, hospitalization, or after discharge. Similarly was in the second co-primary outcome. And in a pre-specified landmark analysis that was done within and after 45 days from the onset of randomization, it was found that the benefit of complete revascularization becomes evident beyond 45 days. And this might be explained, of course, by the fact that the early events after STEMI are largely a consequence of the size and severity of the index infarction itself. Then these events occur to a similar degree in both complete revascularization and then the culprit lesion only PCI groups. And it is only after this initial period, which was estimated to be 45 days, when the incidence of the events related to the index infarction decline, and here comes the benefits of non-culprit lesion PCI, and it starts here to emerge. So we conclude that complete revascularization is superior to culprit lesion only PCI, whether the non-culprit PCI is performed in the index hospitalization or after discharge. And this benefit emerges mainly over the long term, beyond 45 days. And regarding the safety outcomes, namely the bleeding outcomes, the contrast-induced nephropathy, stent thrombosis, or stroke, it was not significantly different between both groups. We all know that the COMPARE acute trial, which was one of the 4 trials upon which the ESC guidelines based their latest recommendations, comparing FFR-guided complete revascularization versus infarct artery-only treatment among multivessel STEMI patients, it showed that at 1 year there was a superiority of FFR-guided approach, and lately, in the 3 years follow-up that was lately released, the benefit of FFR-guided revascularization was consistent over time compared to infarct artery-only strategy. Now coming to the next topic, which is the stent design and whether there is still some stent preferences. Well, actually, we all know that the drug-eluting stents are superior to bare metal stents in the setting of STEMI, but is there incremental benefit for special drug-eluting stent design among the new generation of drug-eluting stents? This was answered by the BioSTEMI trial, which was a randomized trial comparing the ultra-thin strut biodegradable polymer sirolimus-eluting stent to the durable polymer everolimus-eluting stent. The primary endpoint was target lesion failure at 1 year, and it showed that there was a superiority of the biodegradable polymer stent with less target lesion failure, mainly derived by a reduction in target lesion revascularization compared to the durable polymer stent, with a comparable stent thrombosis rates between both arms. This was further confirmed by the latest publication in the JAC, where the all-comers Korean registry reported the outcomes of biodegradable polymer biolumis-eluting stent compared to the latest generation of durable polymer zotarolimus and everolimus drug-eluting stent. And they showed that in standard Cox regression and the propensity score adjusted analyses, both major adverse cardiac events and net adverse clinical events was consistently better among biodegradable polymer drug-eluting stents. Now, moving to the next subject, which is the novel concepts regarding antiplatelet treatment. We all know that with the Triton-TIMI 38 trial and the Plato trials have shown the benefits of prasugrel and ticagrelor respectively in terms of reducing cardiovascular death, MI, or stroke compared to clopidogrel. But this was not without a trade-off in terms of a slightly increased risk of non-CABG related TIMI major bleeding in both ticagrelor and prasugrel compared to clopidogrel. And accordingly, here came the concept, the novel concept of a genotype-guided oral P2Y12 inhibiting strategy among patients with STEMI. The popular genetics study was a randomized open-label multi-center trial recently published in the New England Journal of Medicine, where STEMI patients were randomized in a one-to-one approach to either receiving a genotype-guided strategy of P2Y12 de-escalation according to the CYP2C19 genetic testing compared to the standard treatment with potent P2Y12 including ticagrelor and prasugrel. It showed that the primary outcome, which was a net adverse clinical event comprising all-cause death, MI, definite stent thrombosis, stroke, and Plato major bleeding, showed that genotype-guided approach was non-inferior compared to the standard treatment. And however, also the genotype-guided approach provided less Plato major and minor bleeding compared to the standard treatment. In a similar approach, the GIANT study, recently published in JACC, assessed the feasibility of a routine CYP2C19 genotyping to adjust for thienopyridine treatment after primary PCI for STEMI. It showed that loss of function allele patients in whom thienopyridine treatment is optimized showed no significant difference in the 1-year rate of death, MI, or stent thrombosis compared to wild-type genotype or gain-of-function allele patients. On the other hand, those with loss-of-function allele in whom the thienopyridine treatment was not adjusted or optimized showed worse outcomes. So this brings to us the new concept and the new approach of genotype-guided strategy of P2Y12 escalation or de-escalation, especially of importance in patients that might have a high bleeding risk with long-term use of P2Y12 inhibitors. Regarding the duration of dual antiplatelet therapy, we all know the famous Twilight study. In the ACS arm of the Twilight study, which did not include STEMI patients, it showed that the approach of ticagrelor monotherapy beyond 3 months of DAPT was quite similar to a dual antiplatelet therapy with ticagrelor plus aspirin regarding the cumulative incidence of death, MI, or stroke, with even a reduced bleeding rates among patients receiving single antiplatelet therapy with ticagrelor beyond 3 months. Lately, in the ACC late-breaking clinical trial meeting, the TICO trial have been launched, and this trial particularly approached the new concept of single antiplatelet therapy in acute coronary syndrome, and in this time it included almost 36% of the patients had STEMI. So this trial showed that the primary outcome of net adverse clinical events at 12 months was significantly less in the ticagrelor monotherapy patients compared to DAPT, those receiving both ticagrelor along with aspirin, and this was mainly derived by a reduction in major bleeding. In a pre-specified subgroup analysis for the primary outcome, the result was actually consistent in different subgroups except patients with multivessel disease, where those patients showed that they benefit more from a dual antiplatelet therapy, an extended dual antiplatelet therapy strategy compared to single antiplatelet therapy. And lastly, we come to the last subject, which is the newly arising anti-inflammatory concept in patients post-MI. Experimental data have so long supported the critical role of inflammation in atherothrombosis. It has been found that the benefits of statin therapy and later the PCSK9 inhibitors relate to both reduction in the cholesterol levels and as well as inflammation inhibition and the so-called pleiotropic effect or benefits. Yet there has been no evidence for the benefits of reducing vascular inflammation independent of the concomitant lipid lowering. And this was until lately, when a series of clinical trials have been launched testing the inflammatory hypothesis of atherothrombosis. Starting with the CANTOS trial that tested the drug canakinumab, which was a monoclonal antibody targeting interleukin-1b along the inflammatory cascade. This has been previously used and approved for use in rheumatological disorders, but it was the first time to be tested in a cardiac prevention trial. The CANTOS trial was conducted on more than 10,000 patients, and it showed that among patients with prior MI and active inflammation as evidenced by an elevated high-sensitive C-reactive protein, canakinumab at a dose of 150 milligram given subcutaneously every 3 months led to a significantly lower rates of recurrent cardiovascular events over more than 3 years follow-up. This benefit was independent of lipid lowering, yet the high cost and some safety concerns regarding slightly higher risk of fatal infections in the canakinumab arm, this led to the loss of enthusiasm in canakinumab and the search for another cost-effective lifetime alternative. The recently launched and released COLCOT trial, which tested low-dose colchicine after myocardial infarction as a cardiovascular outcome trial, was recently published in the New England Journal of Medicine. It concluded that among patients with recent MI, colchicine at a low dose of 0.5 milligram daily led to a significantly lower risk of ischemic cardiovascular events than placebo over 2 years of follow-up. But still, this did not include a benefit in terms of mortality, and also still some safety concerns regarding a higher incidence of pneumonia in the colchicine group compared to placebo remained a concern in this in this issue. So to conclude, what's new? Vascular access preference still favors radial approach. Nevertheless, operators' experience and the widespread use of vascular closure devices, which was in the Safari STEMI trial used in about 70% of the femoral approach. This might change the equation in the future, we still don't know. Excluding cardiogenic shock, complete revascularization is now established as the treatment of choice for multivessel disease in the setting of STEMI. So this file is temporarily closed now in favor of complete revascularization. Regarding the stent preference, ultra-thin struts and biodegradable polymer drug-eluting stent designs might confer benefit among STEMI patients. A genotype-guided strategy as a novel concept in P2Y12 inhibitor prescription is a novel concept in antiplatelet therapy post-STEMI. Ticagrelor monotherapy, the concept of SAPT or single antiplatelet therapy beyond 3 months after STEMI, might be considered, especially with the use of new generation drug-eluting stents. However, still some patient subsets, like multivessel disease patients, high-risk lesions like left main lesions or post-CABG, those may benefit from extended DAPT. Anti-inflammatory therapy post-MI is arising as a novel concept in the management of atherothrombosis. Thank you very much.